Welcome to Chapter 12, Carrying Out Implementation and Management, based on planning, implementing, and evaluating health promotion programs by James McKenzie, Brad Neiger, and Rosemary Thackeray. This chapter focuses on how to execute, manage, and sustain a health promotion program after planning is complete. It covers everything from staffing and financial management to cultural humility, pilot testing, monitoring, and ethics. Let's begin with the foundations of implementation and management. Introduction to implementation and management. Implementation is the process of putting your health promotion plan into action. Management involves coordinating people, tasks, and resources to achieve your program goals. First is implementation brings strategy to life. It's where impact actually happens. Second is management ensures the program is not only effective, but efficient and ethical. Health promotion managers must have three core skills: technical skills, knowing how to do the job; interpersonal skills, working with people; conceptual skills, seeing the big picture. Health education specialists have professional responsibilities and competencies that align with these skills. Human resources management, or PADS model. Human resource management ensures the right people are in the right roles. The PADS model outlines four essential HR functions: planning, acquisition, development, and sanction. 1. Personnel planning. First is determine how many people are needed, what their responsibilities will be, and what qualifications they must have. Also consider compensation, schedules, and reporting structures. 2. Acquisition. Second is recruit and select qualified individuals. Use job boards, networks, fairs, or local outreach. Require resumes, applications, references, and possibly background checks, drug tests, or medical exams. Ensure hiring practices comply with relevant laws like Title FISUM and the FMLA. 3. Development. Third is onboard and train staff. Orientation introduces them to the organization's mission and policies. Training builds additional skills, including capacity building, cultural sensitivity, and teamwork. Performance appraisals help guide professional development. Organizations should invest in their teams with budgets for training and growth. 4. Sanction. Fourth is enforce standards and manage personnel systems. This includes fair compensation, promotions, conflict resolution, and discipline if needed. Ensure compliance with OSHA, employee rights laws, and workplace safety standards. Volunteer management. Volunteers are essential in many health programs. Treat their management with the same care as paid staff. First is recruit people who are motivated and well suited. Second is conduct interviews or screening to assess fit. Third is provide training on program background, procedures, privacy, and expectations. Fourth is supervise and evaluate their contributions. Fifth is retain volunteers by making them feel valued. Use inclusion, recognition, and celebration. Sixth is use exit interviews to learn and improve. Enhancing staff and volunteer effectiveness. Well trained, well supported people deliver better results. First is deliver intervention specific training. Ensure fidelity to the program, especially when there are multiple sites or facilitators. Use manuals and quality control systems. Second is form effective teams. Teams differ from working groups. They rely on collaboration, trust, and shared goals. Ideal team size depends on the task, but clarity matters more than numbers. Third is understand how teams evolve. Use Tuckman's 5 stages of team development: forming, storming, norming, performing, adjourning or mourning, and sometimes reforming. Fourth is foster characteristics of effective teams: clear roles, good communication, mutual respect, and shared success. Cultural competence and cultural humility. Cultural responsiveness is non-negotiable in health promotion. First is cultural competence means understanding diverse values, behaviors, and health beliefs. Second is follow the class standards, culturally and linguistically appropriate services. Third is cultural humility goes beyond competence. It emphasizes self-reflection, lifelong learning, and recognizing power imbalances. Box 12.4 outlines 5 core attributes: openness, self-awareness, egolessness, supportive interaction, continuous self-reflection and critique hire from within the priority population when possible, empower indigenous health workers and local messengers, financial management, You can't run a program without tracking the money. First is financial management includes income, expenditures, and record keeping. Second is accounting involves summarizing and analyzing transactions. Use tools like Figure 12.1 to track budget categories and year to date totals. Third is prepare regular reports monthly, quarterly, or as required. Fourth is distinguish between internal audits, routine checks, and external audits, formal evaluations. Fifth is the program manager must monitor the budget carefully. Don't assume someone else is doing it. Putting the intervention plan into action. There are three ways to begin implementation. First is pilot testing, a small trial run to identify problems. Check for fidelity, participant engagement, resources, and delivery quality. Gather feedback and refine. Second is phasing in, rolling out the program gradually. This may involve starting in specific locations with fewer participants or limited services. This method offers control and learning before full launch. Third is total implementation, launching all at once. This is typically used for simple one-time or previously tested programs. Use the inverted triangle model figure 12.2 to guide implementation choices. Monitoring implementation monitoring is a form of process evaluation. It helps you know what's happening in real time. First is collect and review data regularly. Track registration, attendance, activity completion, and unexpected issues. Second is monitor expenditures and revenues. Adjust as needed. Third is assign monitoring responsibilities to someone who will follow through. Fourth is make small corrections early to avoid big failures later. Record keeping and privacy protect participant information and document everything. First is use structured systems for registration, payments, and attendance. Second is maintain records of progress, health status, and feedback. Third is follow privacy laws, especially HIPAA. Know the difference between anonymity and confidentiality. Fourth is use manuals to maintain quality and fidelity for both facilitators and participants. Avoid type 3 errors where a program fails because it wasn't delivered correctly. Ending or sustaining a program, eventually you'll face the question, should this program continue? First is a program may end when goals are met or funding runs out. Second is sustainability is the ability to maintain benefits over time. Third is build a sustainability plan early. Don't wait until it's too late. Figure 12.3 outlines 9 domains of sustainability capacity: funding stability, political support, partnerships, organizational capacity, program adaptation, evaluation, communications, public health impact, strategic planning. Use box 12. 7. For strategies to sustain evidence-based interventions. Sustainability takes planning, leadership, and ongoing value. Safety, ethical, and legal concerns. You are responsible for delivering programs safely, ethically, and legally. A safety and medical concerns. First is obtain informed consent, explain risks, benefits, and participant rights. Use forms and checklists like box 12.8 and 12.9. Second is ensure medical clearance when needed. Third is prepare your site for emergencies and accessibility. Be ethical concerns. First is recognize when values conflict, ethics guide your judgment. Second is follow the code of ethics for health education professionals. Third is apply the Belmont Report's 3 principles: respect for persons, autonomy, and dignity. Beneficence, do good, avoid harm. Justice, treat people fairly and equally. See legal concerns. First is protect yourself and the organization with liability insurance. Second is understand negligence, both omission and commission. Third is reduce legal risk by staying informed, keeping certifications current, providing safe environments, requiring medical clearance, following ethical and professional standards. To summarize Chapter 12, first is implementation and management turn plans into action. Second is strong HR systems or paths are essential. Third is volunteers must be recruited, trained, and appreciated. Fourth is teamwork and cultural humility strengthen delivery. Fifth is program finances and monitoring need continuous attention. Sixth is choose the right implementation method, pilot, phased, or full. Seventh is protect data privacy and standardize procedures. Eighth is plan for sustainability from the start. Ninth is act ethically, legally, and safely always. Thank you for watching this video. This concludes Chapter 12, Carrying Out Implementation and Management, based on planning, implementing, and evaluating health promotion programs by James McKenzie, Brad Neiger, and Rosemary Thackeray. Stay tuned for Chapter 13,